Now I'd like just to give a brief introduction to Dr. Gulick before we pass the reins off. Dr. Peter Gulick received his DO degree from the Chicago College of Osteopathic Medicine. He's double board certified in medical oncology and infectious disease and served as the director of HIV and hepatitis C services at Health Delivery Incorporated for the past decade. He is chairman of the Department of Microbiology and Immunology of the MBOME and has focused areas of interest in HIV, hepatitis B and C, and co-infection therapy. He's also appointed by the state of Michigan, Department of Community Health to the Lung Cancer Advisory Committee, the HIV/AIDS Prevention and Intervention Section, the Michigan Cancer Consortium, and the Region 1 Smallpox Planning Team. In addition to all this, Dr. Gulick has been a great instructor to us throughout our systems courses as an associate professor at MSUCOM. And with all this being said, class of 2023 in Community Integrated Medicine are happy to welcome back Dr. Peter Gulick.
Thank you. Thank you for allowing me to do this today. It's a real, kind of an overwhelming topic to talk about, and it changes every time, you blink. And so what I say today may not be true tomorrow, but I just got done listening. The Infectious Disease Society of America has their national meeting this week, and I listened to an opening presentation by Dr. Anthony Fauci, who I'm sure all of you know, and he's head of the NIH Infectious Disease Unit. And so I kind of got a little bit of a summary of what he said as far as kind of summarizing where we are in COVID as of today, 2020. So what I'd like to do is kind of give you an overall of everything regarding COVID, from presentation to, the statistics about the number of cases, to diagnosis, to lab tests, treatment, and then maybe vaccines. So it's a lot of material, and we'll do the best we can with that. Hold on here. Okay, so looking just at global epidemiology, and I had to go through some data just today to get you updated information, but the global cases of COVID-19 as of today it's 41 million cases globally, and there's 1.1 million deaths in the world. As far as the United States goes, we are number one, unfortunately, in the total cases of COVID, followed by India and then Brazil, but we have a total of 8.4 million cases with 223,000 deaths in the United States. As far as Michigan goes, we have currently 170,000 cases with 7,464 deaths within the state of Michigan. And then if we kind of even go a little further to Ingham County, we have 4,430 cases in Ingham County with 62 deaths. That's our death rate compared to other counties in the state of Michigan is very low, which is very good to see. So that's pretty much the statistics as far as as far as the world and going down. Now, as far as national colleges, national K-12 schools, this is a little bit older data, but within the colleges across the country, there's over 88,000 cases. And so that is a statistic that's growing as we sit here today. And so we have to be very careful, and I'll get more into detail about that. The cases in some of the schools doesn't appear to be increasing like it is at the college level, but it's something we have to kind of watch and be very careful of as we go on. So I'm going to skip this slide because I like this slide a lot better. It depicts exactly what I want to talk about. What are the proposed routes of SARS-CoV-2 transmission? And what you see here is that basically it's the contact droplet mechanism. And so this is where you have a droplet that's greater than 5 micrometers in diameter. And if you cough or talk loudly or any kind of sputum production, those large droplets can go, to another individual. And so that's where it came about to use the mask as well as using the 6-foot distance rule. And the mask is something to do two things, and I'll go more in detail about the mask, but I think it's extremely important for a couple reasons. Number one, that mask can help if you are an asymptomatic shedder or a pre-symptomatic shedder, don't know you have the disease but are still active with it. By coughing or anything into the mask, you're going to prevent that dissemination of those large contact droplets. On the other hand, if you're the individual that's negative for COVID virus and you have a mask on, you may still get virus that you might be exposed to, but the amount of virus is going to be so small that either you won't get infected, or if you do, it's going to be such a small amount that it may actually provide self-vaccination. And there's some articles you can look at. Monica Gandhi from the Harvard Medical School wrote an article just recently, New England Journal, and describing this concept about self-vaccination through this mechanism where you get exposed to small quantities and your body reacts to it, obviously, but reacts in a lot smaller amount than a full blast of COVID virus. And many times that is where we may differentiate somebody that gets a mild infection versus somebody that disseminates into the COVID storm. So that mask actually may provide a couple of very important reasons why it's so important for you to wear it. But going a little further about the routes of transmission, the large droplets then, as you can see, drop to the bottom and go on the fomite area there. So these are countertops. These are cardboard areas, stainless steel. And you've probably read things in the literature, and they've had, different studies through the Massachusetts Institute of Technology where they've actually put COVID virus on different surfaces at a certain amount to see how long the virus lasts on these different surfaces. And there's all kind of things about 2 days, 3 days, 10 days, etc. What is felt now as of 2020, in October here, is that fomite mechanism of transmission may not be quite as important or critical as we thought for in the past. So wearing gloves to pump your gas, doing all these real extensive things to try to prevent these fomites from contaminating yourself may not necessarily be as important as we thought. Now, it still doesn't take away from washing your hands, washing the countertops, etc., because there is the possibility of touching a surface, touching your eyes, touching your nose, your oral mucosa, and maybe a risk, but not as great as we thought. Now, the one that is concerning because of the fact we're going to be going indoors more is the aerosol transmission. Now, the aerosols, as you can imagine, from a sneeze perhaps, or loud talking or singing, projects particles, but they're much smaller, less than 5 micrometers in diameter. The problem with this is if we go indoors, now the air isn't circulating. So we don't have the air coming from the outside in and air from the inside out like you do in an airplane or some that's well ventilated. You have indoor air that's circulating around and around, and these small particles are going to be circulating as well. So a sneeze, a cough, yelling, singing in a closed environment could cause this kind of a particle transmission to occur. And these particles have been found to survive in the air 2 to 3 hours. So somebody could have coughed or sneezed and projected these particles with beyond a 6-foot distance, and you might walk into that area an hour later and still be exposed to a certain concentration. So we're not sure how serious this mechanism of transmission is, but we really kind of worry about it, especially in closed environments. So this is another area that I want you to be aware of. It's something that we're just talking more and more about, and it might be a significant area of transmission. The urine and the feces, especially the fecal material. All of you know that COVID virus can invade the GI tract. There's ACE2 receptors in the GI tract. Matter of fact, some of the most heavily populated mucosa that has ACE2 receptors is in the gastrointestinal tract in the small bowel. However, even though stool has been found to have COVID virus in there, the quality or the viability of that virus, it does not appear to be very extensive. So the transmissibility of that through stool or through other areas of like semen, et cetera, haven't really been felt to be an important mechanism of transmission. So the main mechanism is respiratory, contact droplets, and now aerosolization as well. Looking at the projected post-pandemic SARS-CoV transmission, there's 3 different graphs you see here. Each one depicts something different. So when we had our first pandemic curve that was very high, in the early summer and that projected, we had, 40 to 50,000 cases per day. And then when we started using all the protection and mitigating at home and using face masks and being very, very cautious about so many things, our case number actually went down to low of about 20,000 cases per day. However, as you can see by the first graph, it shows you having a peak, then a trough, a peak, a trough. Those depict areas where we started to open up certain things a little bit cautiously, but still opening up, where we need to open up certain, activities, where now people started to get together a little bit more, but again, cautiously, but still opening it up. And you can see where there's been peaks in those areas. And the more we open up different areas and the less cautious we are when we're opening them up. For instance, the college, for instance, and I hate to use that as an example, but it's a fact, kids coming back to the colleges and then maybe being more careful on campus, but then off campus having parties. And you remember the one restaurant or bar that was, and I can't remember the name of it, where people were waiting in line without masks, close to close. It started with a couple cases, went to 84, went to 100, went to 184, and I forget what the last number was. But again, these are where you start getting higher and higher peaks, where you start opening up different areas. People stop using the protective equipment, the 6-foot rule, the masks, being not in crowds, and now you start getting these spikes. So unfortunately, where Dr. Fauci was hoping that prior to coming into the winter season, we would be down at a valley of about 10 to 20,000 cases per day, we still unfortunately maintain the 50 to 60,000 cases. So now we're going into a period now, and this is the second graph where you see that large peak, where now we're going to go into the winter time. We're going indoors now. We're not staying outdoors anymore. Our classes, restaurants, gymnasiums are opening, all indoors. Lack of ventilated air. Air is not recirculating. Yes, we're washing machines down. We're watching the 6-foot rule, but still things can happen when you're in these kind of environments. And the longer you're exposed to COVID for a period of time, the more likely you are to become infected with it. So 5 minutes in a certain area with somebody may not necessarily get you infected. 10, 15, 20 minutes, now you're talking about something that could be more serious. So because of the fact we're not going to be outdoors anymore, where the virus can disseminate more, we're going to be indoors, we're going to be in closed environments. We've got to worry about the asymptomatic, pre-symptomatic shedders. The feeling is that we're going to get a major curve that's going to occur this winter unless we're extremely, extremely cautious. And again, it's going to be very important. And this is where every state has to look at the numbers. So I think currently we had 1,800 cases. Fortunately, the death rates haven't gone up as high as they did early because a lot of the high-risk individuals are still maintaining high-risk protection, but we still have to worry about more and more cases occurring. The bottom graph is where we start to develop less and less cases. So let's look at vaccinations now and what vaccines are going to do. The R naught of SARS-CoV-2, meaning one person infects how many other people? Well, with influenza, it's a 1-to-1. With SARS-CoV-2, it can be, I've heard projections anywhere from 3 to 4 people. So you have one person infecting 3. Those 3, each one of those infects 3 more. Now we're up to 9, then 27. You can do the math and see how exponentially things can go up just from that easily transmissibility. If we start doing the vaccines and we start talking about what's known as herd immunity, we're anywhere from 60 to 70% now have some type of immunity to COVID-2. One person may only infect one other person or maybe a half of a person. And then you start seeing the curve starting to go down and down in the waves and the peaks and the valleys getting almost to a flat line. And that's what we're hoping to do with more and more of the vaccine coming out. So I just wanted you to see this and be aware of what's going to happen probably in the winter and be prepared for this kind of, an outbreak coming up. So what about the stages of transmission? What do we know about the stages of transmission? And so this is where we have different types of individuals in different areas. So the asymptomatic and pre-symptomatic infection people are the ones that we really don't have a good number on. It's projected, as you can see here, anywhere from 6% to 50%. Today, Dr. Fauci said it's more likely about 40% maybe of people can be asymptomatic spreaders or pre-symptomatic, where they may even have such minor symptoms they don't even realize that it's anything related to COVID-2. It might be a stuffy nose, an earache, something so, a minor sore throat. But these are the individuals we're really, really worried about that can spread a lot of infection to other individuals. And some of these may be super spreaders, where they have a large amount of virus that they can project to infect other individuals. The mild symptoms are just what they say. Usually it's nothing related to shortness of breath. Many times they may have a cough, they may have a headache, they may have some nasal congestion. Nothing really very, serious or worrisome. The moderate symptoms are where now you start getting shortness, or you start getting cough. You get a little bit more dyspneic. You may have fevers, and many times that's when the number one complaint is high fevers, and myalgias, arthralgias. But when you do your oxygen saturation, you're still greater than 94%. Now you get into more dyspnea, more shortness of breath, projecting more coughing, and now you're at a point where you can't even talk without getting short of breath. So you go to the hospital, they do another blood gas, and now you're less than 94%. And most of those patients are put in the hospital. Many of them are put on oxygen rebreathers and monitored closely. The final category is the critical individuals, where they're now in respiratory failure, usually on ECMO or on ventilators, and they starting to develop multi-organ failure. So these are the different stages of individuals. Now, racial sociodemographic disparities is a real concern, because if you look at the overall cases of COVID in the United States, what you'll notice is the whites still have the majority of cases, followed by the Hispanics, followed by the Black African Americans. But when we look at hospitalization rate and death rate, the African American Black population definitely has one of the highest risks, followed by Hispanics. Many times there's the white Indian population, and then finally the white non-Hispanic population are the ones that have the lowest hospitalization and death rate. So what is contributing to that, as far as what is the problem here? And it's felt to be the living conditions. Many of the African American, Hispanic individuals live in environments where they're in crowded housing. They live with multiple families in a small housing group. They have to take transportation like buses and things like that to get to work. The working environment isn't very conducive. They're working in large lines and assembly lines, in closed environments. All the contributing factors to easy spread of COVID-19. Many of them have underlying health conditions. Many of them have poorly controlled diabetes, hypertension, heart disease that isn't under good care. And because of that, it puts them at high risk for COVID-19, not only getting the disease, but getting into severe hospitalization, and then finally into high risk of death. And so this is the concern we have here. And what can be done? Getting these individuals into safer environments, education, safer environments, better working conditions, better control of their comorbid diseases. We're finding even young individuals that are African American or Hispanic, 15, 16, 20 years old. Many of them have obesity. Many of them are diabetic. Many of them are hypertensive. Uncontrolled, they are at high risk. They end up in the hospital on ventilators as well. So this is something that really we have to draw our attention to, and really focus on these groups to try to reduce the death rate and the hospitalization rate by doing as much as we can in this group.
Dr. Gulick?
Yes, question.
We have a question in the chat.
Yeah.
It says, what is the threshold for herd immunity? You mentioned 60 to 70%. Does it vary for different diseases? Because I've heard different numbers, anywhere up to 95%. Yeah,
for COVID, the majority, I've heard different individuals give, but it's around 60 to 70%. This is what's been mentioned for COVID-19. So if we can develop that amount of immunity, then we will have a herd immunity. And I know that there's been different talks about, well, why don't we just do this naturally? I mean, why wait for the vaccine? Let's just let everybody get infected. Well, unfortunately, by developing herd immunity that way, you can imagine how much deaths would occur prior to getting herd immunity. We're not dealing with a benign virus that just causes a sneeze or a cough or a cold. We're dealing with a serious virus. And as you see, as I go on with the talk, you'll see that if you make it off the ventilator, if you make it out of the hospital, if you feel that, oh, I only have minor infection, you may not be out of the woods yet, not even close to it when you see some of the other things this virus can do. So I'll get to that in a little later, but I hope that answers your question. Is there other questions?
No, that was the only one so far. Thank you.
Okay, just interrupt like you just did if there are. Thank you. So
Okay, perfect.
Dr. Fauci had talked about the 5 factors that are very important in the prevention right now. We don't have treatments for this disease. We don't have Tamiflu. We don't have antibiotics, antivirals that we can take if we're exposed or if we have minor symptoms. We have nothing other than doing the prevention that's listed here. So basically, we try to identify individuals that have these symptoms. We test them immediately and we isolate them. And then any of the close contacts we quarantine. The other thing we do is wear the masks. I told you before, and I'm telling you again, these masks have multiple reasons why they're important to wear. To prevent somebody from infecting somebody, and then again from that person that's negative getting infected as well. There's more and more reason why these masks are important. And cloth masks, surgical masks, cotton seems to be a very good material in trapping the majority of virus. These are very important to wear when you're in public or where you can't necessarily get to that 6-foot rule and things like that. And then maintaining social distancing of 6 feet. Now remember, with being indoors now and aerosol transmission, it may be even more important to wear those masks because that 6-foot rule may not necessarily be accurate when you're dealing with aerosolization. So those are very critical. Washing your hands to prevent fomite transmission. Respiratory etiquette, meaning that if you do happen to sneeze or cough, please don't do it in somebody's face or in that direction, but try to put your elbow up to try to limit the amount of dissemination even with the mask on. And then disinfected, frequently touched surfaces. Although I mentioned the fomite mechanism doesn't appear to be quite as severe as what we thought initially. And then the final one, especially now with the poorly ventilated spaces, going to be really contributing. Avoid crowds, close contact settings, and poorly ventilated spaces. So these are the different prevention aspects that we can do, and every one of them is critically important. Is there any question on that? So when you get exposed to any kind of a pathogen, be it an infected virus, a bacteria, whatever organism you want to deal with, basically what you have is you have to deal with the virus growing to a certain amount that then causes symptoms. And this is known as the incubation period. So for instance, with HIV, the incubation period from initial contact till active disease is about 2 weeks. For COVID, it can be anywhere from 2 days to 14 days, although the mean incubation period in many studies has been shown to be about 5 days from the time of initial symptoms till the from the initial exposure till you get the symptoms. And by 11 days, almost 100% of people are symptomatic. So what are some of the primary symptoms? And I'm going to show you a slide that's depicts this in a pictorial type picture, but there's various symptoms. I mean, some of them are very non-specific. Congestion, runny nose, headache. These can all be from an allergic type problem that we see right in the environment right now with allergies. This can be from a coronavirus that causes the common cold. So not very specific. Fatigue, myalgias, arthralgias. Again, depicting somebody with a viral infection. Influenza is going to have very similar type symptoms. Sore throat. Again, very, very non-specific. Cough, shortness of breath. So many of these symptoms are very close to what you would see with either another virus like influenza, another coronavirus, or even flu, allergies type thing. One specific symptom that's very unique to COVID, unlike other things, is the loss of sense of taste and smell. If somebody depicts this type of a symptom, almost without a doubt, it's going to eliminate other causes, and you got to hone right into COVID virus, even if that's the only symptoms they have. No fever, no nothing. So be very much aware of that symptom as being very specific for the COVID-19. COVID-19 also causes GI symptoms. Many of the elderly individuals will many times get GI symptoms like nausea, vomiting, diarrhea. maybe not so much with the shortness of breath and cough. So different symptoms with that. But I wanted you to be aware of the loss of sense of taste and smell as being somewhat unique. So screening and diagnosis, and again, I'm going to go over this again, but when do you suspect somebody positive? Well, the signs and symptoms I just talked about, or a healthcare worker working in a high-risk environment where they're exposed to COVID and where they come out of that environment and they may, be at high risk with symptoms. So a sneeze, a cough, a sore throat from somebody working in a high-risk environment, an ER, a hospital, might be a different type of a concern versus somebody that's living in the basement of their house and has no contact with anybody that all of a sudden gets a sore throat, a sneeze, or a cough. If I'm clearing or if I'm making things clear to you, or if you go to a high community transmission rate, so the community that you're dealing with has a high rate of COVID virus infections, and so you come from there out. And this is where, just to digress just a minute, how do we know about opening schools? Which schools are safe to open for face-to-face contact versus virtual? And what experts are saying is that if you live in a community where the community transmission is very low, where you have very few cases, the possibilities of doing direct face-to-face may be much safer in that environment for students versus a place like where you have a large community outbreak of COVID-19 and you have a school sitting in that environment where the risks are much higher for that school to become infected. And so maybe virtual education might be important there. So a lot of it depends on, how high the community transmission rate is. And in working in a healthcare center, somebody coming into the hospital with a respiratory illness, especially a severe one of unknown etiology, obviously you're going to test for COVID. And then the asymptomatic individuals. And this is where testing becomes so critical. And we'll get into that in a minute, but doing rapid testing, they're doing that right now on the campus here at Michigan State. I don't know if you've seen that or not. If you want to be a thing about the rapid test they're doing now, where they're doing a very a saliva test, and it's a PCR test on groups of individuals that if it becomes positive, then you verify it with a more established test. But at least this is a screening mechanism where you get a number of tests you can do, a quick period of time. The sample is easy to take and you get the results back quick. And that's what they're looking at for schools, colleges, nursing homes, and other situations where, like sports teams, for instance, they get tested, I don't know, every day or every other day, but they get tested very frequently to constantly monitor for any of those early patients or individuals that get infected early or they're asymptomatic, to get them identified quickly and to quarantine them quickly, and then to get around them, get those individuals identified as quickly as well. So these are some of the things we have to be very cognizant of. And this is a good example of what I wanted to show you. Sometimes pictures are better than words. And this just gives you a pictorial kind of a presentation of everything else. The incubation period, like I said, is 2 to 14 days. The symptoms are listed there. Be very, very concerned if somebody presents with a new loss of taste and smell, very specific for COVID virus, unlike other conditions that may cause some of these other symptoms. The most frequent symptom that's been recognized is a fever, and then followed by the cough, and then shortness of breath, and then these other symptoms also percentage-wise goes down. Is there any questions on the symptoms of COVID virus?
Hi, Dr. Gulick. We don't have any questions for the symptoms, but there are a couple of questions in the chat right now. The first is, how long is it recommended to quarantine after close contact? It seems that the CDC changes their recommendations pretty often. And what about false negative test rates in the first 5 to 7 days of exposure?
Yeah, so both good questions there. So yeah, what they're usually recommending is 10 days. And then, if you have the symptoms and everything now if you've just been exposed to somebody and you have no, you're just an exposed person, then it's usually about 10 to 14 days, and that span there. And I think a lot of the data would support the 14. But if you've had symptoms and you're actually infected with COVID, they usually say, 10 days, and then having no fever, no cough, no symptoms at all for 24 hours after the symptoms after that 10 day to make sure you have no active symptoms at that point, fevers or anything like that. So that's usually the quarantine time that they're recommending. And what was the other question now?
What about false negative test rates in the first
False
5?
negative test rate, yeah. So now we get into the specificity, sensitivity of these various tests, and I'll get into that in more detail. But just to kind of give you a quick summary of that, yeah, the COVID-19 PCR test, like if you tested them within the first 2 days after exposure, the sensitivity of the test would be about 30 to 40%. So it's a very low sensitivity. So that means the majority of cases, would be, you wouldn't pick them up, and that because the amount of virus would be so small. And so that would, indicate false negative tests. But as you go further in there, so now by the time you're into the symptoms, after maybe 4 to 5 days, now the sensitivity, of the test, now at least the PCR test goes up to about 95% or so. So the sensitivity becomes very, very accurate, and there's much less false negative tests. The antigen test, which is being looked at now for some of these rapid tests where, it's almost like a pregnancy test. You get the sputum, you do a, analysis on it, and get your results within 10, 15 minutes rather than a day or two. Those tests have a sensitivity of about anywhere from 85 to 90%, and they're improving as we talk. So the sensitivity is not quite as good as a PCR, but you get it back quicker, and you can do more of them because they come back within a short period of time. They're supposed to be cost-wise much cheaper, and the type of specimen you get is something you could do at home. Just put a sputum into a special container, send it off, and you get the results back. The antibody tests, again, don't ever use them for any type of early detection of COVID because they don't become positive until 2 weeks after you've already got the symptoms. And so they're good for establishing that you've been exposed, but not as an acute case. So obviously, if you did that during the first week of infection, the false negatives would be extremely high because of the fact that your body has to, usually takes a couple of weeks for your body to develop an antibody. So I hope that helps answer that question as well. Others?
Yeah, we have a couple more.
Go ahead.
Sure. I'll just read off the ones pertaining to symptoms. Is it common to have GI symptoms and myalgias without the upper respiratory symptoms?
Yes, sometimes you can, and this is where you can get older individuals that will, for some reason, they tend to get a lot of the GI symptoms. They get a little bit of a lack of, besides the sense of the smell and taste problems, they can get into the problems with the, they don't feel hungry, they don't want to eat, they get nauseated, they get the diarrhea a lot of time. And then after that, then a few, a day or a couple of days after that, then they start getting into the respiratory as well. But many times, some of them will present with the majority of symptoms just being gastrointestinal. I can't say that it's a lot, and I can't give you a percentage, but yeah, there have been some where it's just been gastrointestinal, really, and then it eventually gets into the respiratory, but not after several days.
Great, thank you. And one last symptom-related question, and then we'll save the others, because I think you might touch on them a little bit later in your presentation. Generally, how long do COVID symptoms last?
The COVID symptoms can last anywhere from, again, the majority of them will kind of, they kind of peak, and you get the majority of them within the first week. And then during the second week, then they start to decline a little bit. And then they're usually over with by, 14 days. Some people have an extension for maybe another several days. So there's always that curve, that bell-shaped curve. We have some that are stragglers, but the majority of them will resolve. The 10 days, is usually when you start seeing the symptoms, really going away where you have very little to none. So usually they peak in the first week and then they gradually go down after that.
Thank you.
Other questions, or we want to hold on till I go along further?
I think we can keep on going, and hopefully you'll answer some of them along the way.
Okay, but stop me then. We can go back, and if it looks like so this just looks at the disease severity. So looking at the different, what is, we talked about mild infections, severe and critical. What is the percentage of individuals developing each of these different categories? Unfortunately, the majority of individuals develop, only mild symptoms, as we talked about earlier. So 80% or so are mild. However, there's about 14% that then go on to more severe, where they require hospitalization, they require, oxygen, et cetera. And then a small percentage, close to 5%, are critical, where they're in the intensive care unit, usually on ECMO or on the ventilators themselves. And the ones that are at risk for the more severe and critical infections are the high-risk groups. And you can see those there. Age is definitely a parameter here, where greater than 65 years puts you at a definite higher risk. And then if you extrapolate that even further, greater than 70, greater than 80, the percentage goes up, the slope of the curve goes up pretty dramatically with that. So age is definitely a factor. And then different comorbid diseases. So we look at hypertension, we look at obesity, diabetes, chronic lung disease, chronic renal disease, and cancer, all being comorbid diseases that can contribute toward the risk factors for making a patient enter into the more severe and critical stages of the disease. So these are the risk factors that we have to worry about. And I want to emphasize the fact that some of the younger individuals, especially the Black population, Hispanic, that have some of these comorbid diseases, even though the age-wise they're young, they still develop critical problems. They still end up in the hospital on ventilators, and unfortunately, they're still deaths. So even though we kind of always, kind of minimize, oh, you're young, you're fine, you're okay, not necessarily. You got to look at the whole picture, and if they have comorbid problems, which many of them do at a young age, that puts them at high risk as well. So we have to be very, very careful of that. Pregnant individuals, they tend to have, when they're pregnant, they tend to, it's kind of all over the map. And initially it was thought that they didn't have any higher risk than somebody non-pregnant, but they're finding that a lot of the pregnant women do end up in the hospital, maybe not on a ventilator or that critically ill, but they tend to have early pregnancies, and there's been not a major morbidity mortality that's been significant, but something where we still haven't quite defined the risk groups in a pregnant individual. We've only seen very rare, maybe a couple cases of vertical transmission from mother to baby. So that doesn't seem to be a major mechanism or major issue as far as transmissibility from mom to baby as far as COVID-19. But those are just some other areas that we can talk about more. All right.
Hey, Dr. Gulick, one quick question going back to the severity.
Yes.
I saw a news report about blood types being correlated with disease severity. Have you heard of this, and whether this has any evidence behind it?
Yeah, and it's something, and I don't remember the exact mechanism, but I believe it's type O that has the very good, prognosis, and then type A and B. And I forget the mechanism where it has something to do with the stimulation of the immune system, where the O doesn't have nearly the aggressiveness as far as stimulating the immune system and causing this COVID storm to occur, whereas the A and B have that ability. And I remember reading it, but I don't remember the specifics. But there is some tie with the blood types in the immunological reaction to the COVID virus, because this is where we get into the trouble, really. This is what the whole critical problem is, the thromboembolic problems and the COVID-19 storm that occurs. And it's felt that the blood group O doesn't have that type of a severe stimulation or reactivity to the COVID that the other blood groups do.
Thank you. And we have one other question. How long does it take for taste and smell to return? Is it possible to have permanent changes in taste and smell after being infected with COVID?
Yeah, and it's that particular symptom occurs in the olfactory bulbs, and it's worrisome that may even be an open door, a predictor of any neurological problems that can occur in people with COVID, because as you know, neurological complications of COVID haven't even been fully identified yet. We know that patients can get an encephalitis, they can get stroke, they can get small vessel ischemic changes from the hypercoagulable problem. And so this sense of taste and smell may predict somebody that may be at risk for that problem in the future. But as far as the length of time, some people clear it within the first week or 2 weeks of it, and some people have it beyond that. And I've talked to a couple patients that have developed that, and it's even months later, and they still haven't quite got the taste and smell back yet. So it depends. You know, everybody's different. I think the majority do clear it within the first month, though.
Thank you. We have a bunch of questions about the sensitivity and specificity of the test, but I think you'll touch on those here.
Yep, we're right here on testing as we speak. So the first test is the PCR test. So this is the test that looks at the actual genetic material of the virus. So you do the nasopharyngeal swab and you get the sample back, and you're looking actually at the genetic material. Now, the genetic material, I want you to understand, doesn't mean viability. All it tells you is you tested the virus. So there's been cases where you can have what's called a false positive in the fact that months after you've cleared the virus, you have no symptoms whatsoever, and you do a nasopharyngeal swab and you still find the genetic material up there. Yet when they put it on a sample to see the viability of that, it doesn't grow any virus at all. So it's genes, but it's not active or anything related to virus activity. So you have to understand the limitations of that test. But it's a very sensitive test. Of the testing that's limited or that's indicated there between the PCR and antigen test, it's definitely a very, very sensitive test. And obviously it's a very specific test as well. Specificity means that it won't confuse it with one of the other coronaviruses that cause common cold and things like that. So it's a very sensitive and specific test. It's useful. Like I said before, if you do it too early, you're going to pick up false negative tests because there has to be a certain volume of virus that's present before the test becomes positive. And so some of the early asymptomatic cases where it's positive, you have to be very, very careful because they could still develop infection, and you have to monitor them closely and retest them if you feel that they've had a high risk exposure and they definitely are individuals that are positive. So it's useful in those cases. The nasopharyngeal swabs, they looked at different sampling areas, like the posterior pharynx, the nasopharynx, the mid-turbinate area. They've looked at the bronchial, the lower respiratory tract, because now we're looking upper respiratory, but they looked at lower respiratory. For instance, doing a bronchial lavage or things like that for the COVID virus. And what they found is you can see the sensitivity and specificity of the nasopharyngeal swab, 97% sensitive, 100% specific. The mid-turbinate swab is just, if maybe a little even more sensitive than the nasopharyngeal. And so this is, again, these tests are very sensitive and specific. When you look at the issues about it, though, you have to be careful when you're doing those nasopharyngeal swabs that you don't go too high up because there have been fractures of the cribriform plate, there's been some spinal fluid leakage, there's been some trauma induced with these tests, and you have to look at the amount of time it takes for them to come back. Now, fortunately, we're getting them back much quicker than earlier where it took a week for it to come back. Now we're getting it within a day, but we need tests that are a little bit more rapid as far as our ability to get them back. The antigen test is, again, a test that looks at the specific, part of the virus. And we're looking at, and again, it's an acute phase test where we use it for acute infection. So we are looking at it for asymptomatic individuals, acute cases as well. It is a test that can be done more rapidly on other specimens. So they're looking at saliva tests where you can spit into a cup or into a little container, and it can be utilized in that mechanism as well. And it can give you results within 15 minutes to 30 minutes to 60 minutes. The sensitivity here tends to be a little bit less, as you can see there, 85 to 90% sensitive, but it's still very, very specific. So false positive tests are very, very little. And they can do what's known as pooling tests. So let's say you have a class that you're going to and there's 20 people in there and you want to test everybody before we have class. So what they do is they'll take specimens from all 20 people, put it into a container, do the test. If it's all negative, then we assume everybody's negative there and they go to class. If the test comes back positive, then unfortunately every one of those 20 people have to be tested. So it offers testing to a larger group of individuals that hopefully then allows us to test more and more individuals. Now, before I go any further, the test that's being done at Michigan State is actually a PCR test, but it's done in there's different ways of doing PCR tests through thermal regulation and other test mechanisms. The mechanism this is being done is still, we're able to do the test, but we are able to get it done quicker and with specimens like the sputum. So this is something that is looking at a PCR test, but doing it in a quicker manner. And so the last test is the antibody test. And I have a picture to show all these tests together, but the antibody test checks for just that, the antibody reaction to the COVID virus. And there's an IgM antibody, IgA antibody, and an IgG antibody. And the total measures both IgM and IgG. This usually takes 2 to 3 weeks after symptoms occur before it becomes positive. So it's not for acute diagnosis. And the problem with this test is there's binding antibodies, binding site antibodies, and there's neutralizing antibodies, and it tests for both. So the problem is you can't say that because you have an antibody that you're immune to COVID-19. Not at all. This test just tells you you've been exposed. We don't have that amount of information yet to say you're exposed, but you're also immune to the COVID-19. Like you, for instance, if you got the hepatitis B antibody, you're immune to hepatitis B. So we have antibody tests that we measure that show us immunity to certain, viruses and that are very accurate. This does not tell us that as of yet. So we have to be very careful how we interpret it. It means exposure, but it doesn't mean immunity. What they're working on now is a more detailed, accurate test to differentiate neutralization or neutralizing antibodies from binding antibodies. And with that, we're going to have more ability to talk about who's immune, how immune are they. And this will be important because we're going to have this kind of test for vaccinations. We're going to have to know who's immune, who's not, and then how high the immunity is by doing different titers. So with that kind of explanation, and I'll go one more slide to give you a pictorial definition of what I just talked about. So you can see -1, -2 weeks prior to symptoms. You can see that what we're looking at is, the detection availability, and it's very low. You can see the curves are just starting to go up as far as, and you can see on the right-hand side, the red is depicting the nasopharyngeal swab, and then you can see the bronchoalveolar lavage stool, and then the dotted lines are your antibodies, both IgM and IgG. And you can see how the different curves drop over a period of time where the sensitivity of the test is reduced after, with the nasopharyngeal swab, after about the second or third week, you start seeing a decline where you start getting, testing that you may still have the virus, but it's not being detected with the nasopharyngeal swab test. And again, after 3 weeks, the viability may not be there. It may just be useless or, non-viable genetic material. But you can see where the antibodies persist, especially the IgG. So with that being said, how about questions on this?
Hi, Dr. Gulick. Yeah, we have a lot of questions in the chat. So the first one is, are there known rapid testing sites in East Lansing or Lansing?
I don't know of any offhand, and that's a good question, but I don't know of any offhand other than, like I said, what they're doing on campus right now. And I tried to get into the website to get a little more information before I did this talk today, and I managed to get a little bit of it, but it's something that you could go. They're doing this saliva test that is a test that's, like I said, it's a PCR test, but it's looking at saliva, and it's an experimental test in that you can't say that if you're positive, they want it verified by a more detailed test. So it's still going to take you a little time. But what they're saying is that if you get this rapid test and it's positive, you go into quarantine and then you get the more specific test to see if indeed this is a true positive. But yeah, I don't know of any rapid test at this point. I think Sparrow is starting to look at some right now, but I haven't heard, how effective it is. But I think we're going to need these rapid tests, even though the sensitivity may not be quite as good as the PCR test, or at least the nasopharyngeal PCR, for, different environments like nursing homes, gymnasiums, for sports teams, for classrooms where they're going to do live classes and things like that. I think that's going to be important, that we have to get that kind of information.
Okay, the next one is Dr. Nassiri mentioned concerns of nasopharyngeal swabs leading to anosmia because of introduction of virions to the olfactory plate. Can you address this?
Oh, that's a good question. And to answer that question, I don't have an answer to that, because where he's talking about is projecting putting the virus up higher into the, up to an area where it might actually transmit itself to the brain and cause further problems. I've never seen anything written on that. I've never seen, not that there isn't, but I've never seen that as a complication. But theoretically, I guess you could say that when you're using a cotton swab and you're trying to get the good specimen and you're pushing, could you, contaminate some other area with that virus? It's a good question. I don't have an answer to that.
Okay, and the next one is if the antibody test is not useful for acute diagnosis or for immunity, what is it useful for?
Just to say who's been infected, to try to get a little basis on, you're in a community now, and how many people have actually been infected with COVID. Maybe a lot of them didn't have the symptoms, or they had symptoms that they didn't feel were truly COVID. Or somebody will say, like I have patients come into my office, about 5 weeks ago, 4 weeks ago, whatever, I had a horrible cough and I had a fever and just felt terrible. And I didn't go in to be tested, but boy, I wonder if that was COVID in retrospect, and this and that and the other. And they really want to know if they've been exposed to COVID. You could get, an answer as far as that goes. And then you could see the community itself, in a community in Ingham County or somewhere, how many people have really been exposed to COVID that didn't know it, that were asymptomatic, pre-symptomatic, symptomatic, but didn't know they were COVID infected. So it gives you a community kind of an overall view of how many people have actually been exposed to the virus. But by all means, it's very, very, for all you students out there, if somebody asks you questions about that antibody, make sure they understand they're not immune. They still have to take all the precautions that somebody without that antibody has to take, because there has been some couple cases of what's known as reinfection, where they've isolated genetic material a month or so after a person has been infected with COVID. And now they find that the genetic variant of this new isolate that they found was totally different from the initial isolate that a person had. And what they're finding, and what's a little bit nervous, I don't want to make a lot of, develop a lot of fear in that, but where patients have developed the first bout of COVID and it was a minor symptom, and many of these asymptomatics or pre-symptomatics, you think, well, they haven't had the symptoms, so maybe they haven't developed immunity. And they've actually found that where they've tested patients who are asymptomatic with antibodies, and they found their antibody response wasn't as high. So these might be individuals that might get reinfected, and the reinfection may actually cause worse symptoms. It might be that they've been sensitized to it, and now the reinfected virus causes a burst of, more immunological activity in the cytokine storm, so to speak. Long answer to your question. I hope it answered the antibody test, though.
Yeah, it definitely did. And I think it answered, there's another question that said, do we know if the antibody test stays positive, or does that drop off in 3 months?
Great question. And that's the exact right answer, too. We're finding that it doesn't last very long, and different people lose it at different rates. And that's where people that tend to have a more serious infection with COVID tend to have a higher titer of antibody, because they do measure titers of this too, 1 to 16, 1 to 250, that kind of titer. And so by measuring titer, and they find that those that have more serious infection have a higher titer and may keep the antibody longer, whereas the ones with minor infection may lose it within a couple months, like you mentioned, 3 months or so. So another reason to be very, very cautious in telling people, look, this antibody just means, yes, you've been exposed, but don't go any further with it as far as, trying to convince yourself that now I can go and party and don't wear a mask and don't do anything. Please make sure they don't do that. This virus is an RNA virus. It's got one of the longest strands of RNA of many of the viruses there. So it's got, but it very rarely mutates. You may question me and say, well, I heard it mutated or something like that. Well, there's been a couple cases where they say, yeah, it may have developed a change in a couple, segments there where it might be more easily causing easier infection or something like that. But there are definitely no increased risk of more virulence or anything. But as far as the overall mutation rate, very, very low. It's got a codon in there that actually when mutation occurs in the RNA, there's a little code that actually snips that abnormality out to keep the RNA rather stable. So it really speaks very good for a vaccine being effective and maybe not having to be changed every year or 6 months like we do with the influenza.
Thank you. And there's so many questions. Thank you for everyone's patience with answering them and me asking them too. A couple more questions. Would the PCR still be positive after symptoms have resolved? And
Yes.
How long can an individual have detectable amounts of IgG in their serum for following a COVID infection?
Okay, so I think I heard two questions there, if I'm not mistaken. The one is, so symptoms resolved now, you're beyond 14 days and 10 days, 14, and no symptoms anymore, no fever, no cough, nothing, you feel great. And somebody, for whatever reason, does a COVID test on you and does a nasopharyngeal swab up the nose. And lo and behold, there's COVID, there's genetic material. What does that mean? Does it mean reinfection? Does it mean persistent infection? Does it mean just nothing, just genetic fragments? The majority of cases they find just means that, and again, without symptoms, that it's just genetic material there that happens to be laying there. They've tried to culture it and tried to see if it's viable. It's not viable. So it just means that it's been there, but not anything viable or anything. So people can actually have it there a month after they've had their symptoms resolved. As far as the antibody levels go, I forgot exactly which question, but the antibody.
The question was, how long can an individual have detectable amounts of IgG in their serum following a COVID infection?
And this is an ongoing project because, this disease was only recognized back in December. And so we didn't even develop the technology for this until a couple months later. So we're just following these people, and I'm sure what's being developed now is data banks in certain parts of the country. So they're trying to develop data banks for serology and data banks for other, looking at other things about COVID-19 to try to develop, to get more and more data on these different questions that you have. And so they're doing data and doing testing on these individuals, every so often to see exactly how long patients will maintain an antibody and when it's reduced, and trying to then trying to perfect an antibody that's going to give us information on immunity rather than just binding sites and that. So these are an ongoing things, but we know people that have maintained antibody for 3 months or so and still had antibody. But again, we're not sure if that's going to, maybe 6 months it goes down. We don't know yet.
Okay, and then the last question about testing, I think. What is the reasoning for the swab having to go all the way up to the nasopharyngeal space? Is the viral load higher there?
Yeah, I think it's because the virus, it's another good question. I don't have a very clear answer for it, but I think the virus, mainly colonizes the respiratory tract, the upper respiratory tract as well as lower. And so the virus has different areas where it colonizes. And like I said, the mid-turbinate area tends to be one where you can get a good swab as well. But a large higher concentration tends to be in those areas. That's why apparently sputum and some of the others, or spit, for instance, saliva, may not have as much of a viral load in there that can be measured unless you use a much more accurate, sensitive test that can amplify, like if you only have a couple little fragments of genes where it can amplify it to a degree where you can actually measure it.
Okay, thank you. I think those are all the test questions, but we'll ask some more later.
Yeah, sure. And they can reach out, talk more about the test as well. We're actually at 1 o'clock. Is everybody still okay with going on?
Yeah, absolutely.
Okay, I'll go with you then. So medical management. So this is where we look at the different symptoms and how do we handle those clinically? Well, if you have mild symptoms, if you have somebody that has a sore throat, a headache, my grandson got exposed to COVID and his main symptoms were headache and sore throat. And he got quarantined for 14 days and or 10 days rather, and then no symptoms for 2 days afterwards. He was tested positive. And so he was monitored at home, and he kept home in quarantine for that period of time. So most of these individuals can be just monitored at home. When you start getting into moderate symptoms, though, now many patients can still stay at home. Moderate means that now you've got headache, you've got fever, you've got a sore throat, but now you may have a cough and you may have a little bit of, shortness of breath, but nothing enough to really, do anything or anything. And most of the time you're stable at home. However, be very, 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 very careful, because a person can be very stable on day one, and then 24 hours later can progress to severe in where they were complaining of a cough, say today, and then tomorrow all of a sudden they said, my God, I can't even walk to the bathroom. I can't breathe. My chest is tight. I can't breathe. I can't even walk 2 feet. So they can change very quickly and have to be monitored. If a person is older with comorbid diseases, even if they have moderate disease, sometimes they're recommended to go to the hospital and be monitored closely. And at that point, you can start looking at labs to see if there's prognostic information that might indicate somebody that might be at a prognostically, might be a little bit more advanced, with some of the lab findings. And so I'll get into the labs a little more, but some of the different tests that, if you had a D-dimer, for instance, that was going higher, this would mean that you could be at an increased risk for hypercoagulability and some of the hypercoagulable problems. If your CRP went high, and there's certain levels, stages that they look at for these things, IL-6, these are inflammatory markers that can indicate a higher risk for somebody progressing. If you did a chest x-ray and found multi-lobe infiltrates, it might be something more significant than a chest x-ray showing just one minor infiltrate. So these are some of the things that you might have to monitor in somebody that might be high risk to indicate who should be admitted and who could be significantly taken care of by home. Once you get into the severe cases, now you're in the hospital. Now you've got supplemental oxygen and support, and then monitoring very closely for any kind of change in oxygenation and any type of multi-organ failure, change in renal function, change, in your heart rate, for instance, where you start developing, changes in QT prolongation or something EKG-wise, which might indicate a myocarditis, something that might be more severe. And then the labs definitely are going to be important at this stage as well. So let's go a little step further here. And then when you get into the critical stages, obviously you have the ventilator support or ECMO, and then you got to worry about all these other conditions with, the hypercoagulable state, with venous thrombosymbolic problems, hematologic, et cetera. And I'll get into the treatments, where the treatments really parallel what's happening clinically and pathophysiologically. So these are the different stages. And then we get into, now I'm going to pass these by, not because but I want to show you one that's much more representative. This is a much better slide to show what I was going to just talk about. There's many, many, many extrapulmonary manifestations of COVID. This just scratches the surface. We're learning about this as every day, but look at the dermatologic problems. You can get conditions where you get the blue toes, so to speak, where somebody looks at their toes and they're blue, and it's mainly because of a vascular problem. There's ACE receptors on the endothelial cells of all the blood vessels. And when those ACE receptors get stimulated, they can cause different types of problems. They can cause more vessel instability. And then you get a hypercoagulable situation that causes a clot to form in there. And now you have a thromboembolic problem. But these are all the dermatologic issues that one can see with COVID-19. The cardiac problems are astronomical. We're really worried about that. And they say that about 60% of people that get serious COVID, not even serious COVID infection, might have a degree of cardiac manifestation. And I'm actually doing a lecture for the cardiovascular system at MSU, and I've devoted it just to cardiac manifestations of COVID-19. It's such a big area, but you can just see the different things that go along here and can cause anything from, myocarditis to myocardial ischemia, to acute coronary syndrome, cardiac arrhythmias, and then acute cor pulmonale or cardiogenic shock. These are all different manifestations that can be caused either from loosening of the plaque, like a person that's got a pre-exposed problem with coronary artery disease and has a plaque, the coronavirus can actually cause instability to that with the ACE receptor endotheliitis, causing plaque instability and causing coronary syndromes, versus just inflammation of the vessel causing increased risk of thromboembolic phenomena with platelets adhering more freely and coagulation system. And then the inflammatory component by itself with the IL-6 and the IL-2, et cetera, all the TNF and all that other stuff. So that's a huge area. And we're actually worried that we're worried in our younger people that they may have a small degree of myocarditis, where it could lead to instability of the heart muscle with arrhythmias. And so they're testing athletes for this. They're doing actually cardiac MRIs to try to evaluate it in a much more detailed manner. And this may be a long-term problem. Endocrine, hyperglycemia, diabetic ketoacidosis, gastrointestinal, GI, diarrhea, nausea, vomiting, abdominal pain, nausea, anorexia. Again, depicting the fact that the GI tract has huge amount of ACE receptors on there. And then neurologic, another area where I'm probably going to develop a separate lecture on because there's so much involved here. They're talking now about people recovering from COVID getting the brain fog, meaning that they can't think clearly. They have cognitive changes. Are these temporary? Are these permanent? We don't know. They're actually developing clinics called long haulers clinic, where people that have chronic conditions post-COVID recovery are going to, because many of them have chronic conditions that haven't improved. Respiratory, cardiovascular, neurologic, hepatic, renal, etc. But you can see the different complications there. Thromboembolism, this is huge. COVID doesn't just cause a cytokine storm, it causes a hypercoagulable condition caused by both the endotheliitis, which makes the blood vessels damaged, very sticky, and then you have activation of platelets that stick to the vessels that cause a coagulation cascade to get activated, and now you've got a heck of a problem with thrombi occurring everywhere. And the D-dimer is a very good marker of this occurring. Hepatic, elevated liver enzymes. You have to be careful in people that have pre-existing liver problems like hepatitis C, hepatitis B, chronic liver disease from other causes that they might get severe. And then finally, renal. It's depicted that about 40% of people with COVID infections that get admitted to the hospital have renal abnormalities and have acute renal failure. Many of these end up developing chronic renal failure that are dialysis dependent. So again, all these areas are extrapulmonary that we're starting to understand more and more, but COVID is not by any means just isolated to the lungs themselves. And this gives you an example of some of the, look at the radiologic and lab abnormalities in people that have non-severe, maybe moderate disease versus severe disease. Look at the CT scan, x-rays, few infiltrates versus multi-lobe infiltrate. And these can change within a day, 24 hours. White count, median white count, 4,900 versus 37. So as the patient gets more severe, you can see the white count dropping, starting to become more serious. And the real serious parameter here is the lymphocyte count. So if you start noticing lymphocytopenia, that's a bad prognostic sign. That means the patient will most likely progress from severe to even critical. So that has to be monitored. Platelet counts, again, noticing a drop there. And then looking at the acute phase reactants, looking at C-reactive protein. I don't have IL-6, but that would indicate the same thing. 55% abnormal, a certain level, versus 81% in somebody with with severe disease. And then looking at some of the various enzymes. And then the D-dimer depicts coagulation problems. So when you get a D-dimer that's markedly elevated, there were cases where the D-dimer is over 25,000 milligrams per liter, and those individuals, you couldn't get an IV into them. They clotted every vessel in their body. So it's a very serious problem that we see, in some of the labs, and inflammatory markers help us to try to categorize people into who's severe and who's not, and trying to develop therapeutic measures to try to treat these people. The troponin level is another monitor we use for cardiac disease. So a high troponin level tends to indicate more serious cardiovascular disease. So these are just different infiltrates in that. Is there any questions on these?
Yes, Dr. Gulick, we have a couple questions here. First, is there a specific list of inflammatory markers being used for patient monitoring to guide primary care physicians in management and deciding when to hospitalize patients?
And when to what now?
Is there a list of specific inflammatory markers being used for outpatient monitoring to guide primary care physicians into management and deciding when to hospitalize patients?
No, I don't know of anything yet where that's being done. I mean, it helps to build your case for sending them in if you notice things, but there's been no cookbook or anything yet where that's been developed. Not that it won't in the future, but right now, no. In the hospital, though, and I don't work in the hospital anymore, but I talk to the fellows, the ID fellows who take care of seriously ill COVID virus and COVID. They do use these inflammatory markers a lot of times to help them, monitor patients, and especially the D-dimer when it develops into a high enough level, whether you use prophylactic anticoagulation versus therapeutic anticoagulation. There's a big debate about when to use one versus the other. And nobody has an answer right now, but they use the D-dimer sometimes to try to tip them over into maybe using more therapeutic versus prophylactic. So that's one marker I know that they're using, for trying to develop type of therapy. But for other things, as far as, when to use remdesivir, steroids, things like that, no, these markers haven't been, developed enough to do that as of yet.
And a follow-up to that question, is there a recommendation on how often these labs should be checked to help keep stable patients home but not miss that threshold when they should be going to the hospital? Asking as a PCP.
No, nothing has been developed in that area as well. This is something pretty new, and they're just developing these parameters right now. But no, they're using mainly the symptoms and the oxygen levels as far as depicting, who should go in the hospital, when it's, when the oxygen sats less than 94%, they feel strong, you should go in the hospital and get on a breathing mask and, or rebreather, or nasal cannula, whatever, and get oxygen, because at that point you do have significant risks of progressing. And the more comorbid problems you have, the more at risk you are for developing complications. So a young individual with dyspnea and shortness of breath with an oxygen sat less than 94% has a different type of prognosis than somebody that's 60 years old, 65 with hypertension, obesity, and diabetes. So they're going mainly by those signs right now as far as trying to categorize them.
Thanks, Dr. Gulick.
Yep.
We have a couple questions here from earlier parts of the presentation, if that's all right.
From what now?
From earlier portions of the presentation.
Yeah, sure, go for it.
So this question here, do we know why fomites are not as much of a threat as thought before?
I think the reason being is that they started looking at, when you start looking at infectivity of different things, like for instance, when they tried to say, well, how long is blood positive for HIV and how long would it be on the surface and you could still get infected with it? The quantities of virus they use are sometimes so high that they don't mimic what could happen in a real patient. So they don't really have that kind of a, that finely tuned, to draw conclusions and to make recommendations based on that. Because what they did was they looked at various concentrations of virus and then just tried to reculture them after certain periods of time on different surfaces, but they didn't know how much they, some of it they just cultured virus. Well, does it mean that, 10 to the second quantity of virus, is that an effective amount of virus that could infect somebody, or is it just the fact you've isolated it? Isolation doesn't mean infectious potent. So they really didn't clarify to that, degree. Plus they know the half-life of this virus changes depending on what surface. So it may be 6 hours or 10 hours on a cardboard surface, and it may be a lot longer on a stainless steel surface. So there's so many issues there, and they feel that the studies really haven't been clarified enough, but the ones that have been don't really show that it's quite as infectious. And plus clinically, we haven't seen cases that have been transmitted that way necessarily. So I think a lot of these are contributing to the fact that not that we're saying that fomites don't, and we're not saying don't wash your hands, don't clean surfaces, but not to the point of being obsessive about it.
Great, thank you. So these next two are kind of related to the spread of the virus. Do you believe that 20% of the COVID patients spread it to 80% of the people, or is that a myth?
Boy, that's a good question. I don't know about that. I know that, we worry, the one factor we don't have a good, these asymptomatic shedders are the ones that we really worry about because, how much virus do they really have? And they've done studies in other countries where they've actually done quantitative evaluations on viral loads in some of these early asymptomatic, and it's kind of been all over the map where they found high levels in asymptomatic shedders, sometimes higher than before, than when you become symptomatic. And then other studies didn't show that as much. So yeah, I think the worry has been that these asymptomatic or pre-symptomatic shedders do offer the problem with spreading it to other people and may actually be super spreaders if they actually have large volumes of virus on board. But yeah, to say that 20% infects 80, that I don't know. That I haven't heard of.
Okay, thank you. And for this question, how does one respond to the statement that COVID is just like the flu? Are there certain talking points that we can share?
Yeah, COVID is not like the flu. Please don't say that or don't even think that, because COVID, I've just scratched the surface with what we know about what COVID can do. And we don't know the long-term consequences of COVID as far as what it may do and persistently do in people that recovered from it, as far as the lungs, the heart, the kidneys, and the brain. We don't really know the long-term consequences, but the inflammatory reaction to COVID, is incredible. The thromboembolic reaction to COVID, it's nothing like what we've seen in the flu before. And so, you have to really be very, very careful. Plus the R naught, meaning the infectivity of COVID is much higher, meaning one can infect 3 to 4 people versus the flu is 1 to 1 usually. So the infectious potential of the COVID virus is much, much more infectious. And so we really have to be very careful and not draw a parallel with COVID and the flu as far as, kind of minimizing the true effects of COVID. It's a very, very scary virus. And dealing with viruses my whole career, this virus, in what it does, and we're scratching the surface now, it's an incredible virus in what how it affects the body in general.
Great. So just to clarify, if we're spending time talking to our family or friends about this, would it be fair to say that in comparison to the flu, COVID has a higher infectivity rate and also affects different symptoms in the body more severely?
Yes, and I would say that's a good way of looking at it, yes. And by taking the precautions for COVID, you've got 2 for 1. You're going to we're going to see a drop in the flu as well. And I would recommend too that all the students make sure that they, as well as their families, get the flu vaccine, because even if it's only 50 or 60% effective, it's still going to hopefully decrease your chance of getting the flu and maybe compounding the flu and COVID together, or at least reducing, your chances of getting the flu. Because a lot of times the flu doesn't lead to respiratory problems, but it still leads to a lot of, myalgias, arthralgias, fever, and it may weaken the immune system enough that you might be more susceptible to other things.
Thanks. There are a couple of questions here about specific treatments and then also vaccines. Will you be touching on those topics later on?
Let me go on here. That'll be my segue there, because I'm getting into that now. I'm getting into the pathophysiology, and I'm going to go into this because this is where I think as medical students, where you see the bridge between basic science, clinical, therapeutic type thing. By understanding the basic science principles, you can see where some of the clinical symptoms fit in, and where even more so with COVID, how the therapeutic principles presented as well. So to begin with, first of all, the virus utilizes the ACE2 receptors, and everybody knows the ACE2, receptor, converts angiotensin 2 to the angiotensin subtypes. I think it's 1 to 7. Angiotensin 2 does cause vasoconstriction, does cause increased elevation in inflammatory markers, does cause oxidation to occur, and several other factors. So what the COVID virus does by attaching to the ACE2 receptor is it downregulates it. So it prevents the angiotensin 2 from converting to the angiotensin 1 through 7. So there's more of that. So that causes more receptors to more contributing to inflammation, to vasoconstriction, to oxidation, to a lot of the avenues that we see occur with COVID too. So that's one mechanism. And the ACE2 receptors are on multiple organs, not just the lungs. They are highly involved in lungs, but they are seen in the GI tract, renal, definitely the endothelial cells, surrounding the blood vessels. So it's seen in many tissues. What happens then is the cytokine storm, which I'm going to show you pictorially and describe it a little better, as well as the thromboinflammation that occurs. And so I'm going to show you this in the next slide. So this is the thromboinflammation. So what we have on the right side, my right side, maybe your left, but my right side, is we have a bunch of contributing factors, atherosclerosis, hypertension, that lead to some disruption of the vessel wall of somebody that has, different conditions, severe burns, those all cause vessel irritation and damage to some degree. So we have, different risk factors that could cause, damage to the vessels by themselves without anything more said. We know that the COVID virus can cause inflammation of the vessels because they attach to the ACE2 receptors and they cause disruption of the ACE2 receptors and can cause vasoconstriction and other abnormalities as well. Well, what happens then is that you get these other conditions occurring there because of this vessel tissue factor stimulation and irritation, and you get a hypercoagulable state. And there's other conditions that can cause the hypercoagulable state as well, like sepsis and different things, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, which are both, von Willebrand factor related platelet aggregation and adherent. But this is the nice circular drawing here that we can see where we have, the Virchow's triad of COVID virus 19, where we have endothelial dysfunction and altered blood flow because of what's occurring is vessel wall endotheliitis or vascular endotheliitis from the ACE2 receptor stimulation, and then causing platelet activation that may occur from the virus causing it versus just unstable vessel walls, and then causing all these different factors to occur, factor 9 or factor 11 activation, von Willebrand factor, where we get the contribution of the platelet activation, as well as almost like a TTP DIC type combination occurring, where we now have increased risk of thromboembolic phenomenon occurring in different vessels of the body that can lead toward organ dysfunction, both in the kidney, the lung, all over. And when they've done actual pathology evaluations of different organ systems of people dying from COVID-19, they found that there's a lot of vessel involvement with clot in the lungs, the kidney, and different other organ systems of the body. So this is one mechanism of COVID-19 infection. The other mechanism, and I'm going to go right to this stage here because I want to basically get you into this, is through the immune response. Now, this is where I talked a little bit about, are you exposed to a lot of virus or a little virus? So let's go right here where we see the patient getting exposed to COVID virus. Now, he's got a low virus titer, either because the exposure was very limited or minimal, or maybe he had a face mask on and he just got exposed to a little bit of it. So now he gets a reaction, which he should. He gets activation of his monocytes, macrophages, which are definitely responsible for cytokine production, but not a high degree of cytokine production. He gets a low degree of cytokine production, and then he may get isolated at home or even hospitalized, but his immune response is normal. He has a quick type interferon 1 reaction, and interferon 1 is what really controls the virus. So if you get good interferon 1 activation, you're going to control that virus quickly. You're going to get activation of the macrophages and monocytes, and you're going to get some cytokine production, but not a high degree. And then you're going to get activation of the cell-mediated immune system, the CD4s, CD8s, and CD8s are very important for cytokine or for COVID-19 control. And CD4 is either a Th1 response or a Th2 response. The Th1 response is more intracellular, looking at viruses. The Th2 response mainly produces broadly neutralizing antibodies. And so there's many responses, but if you get a normal immune response, then you're going to recover. You're going to have a mild reaction, you're going to have a mild cytokine reaction, and you're going to recover. Let's look at the other side of the equation. You get a significant high viral titer exposure. Now you get a delayed, limited interferon response. Your body tends to overreact. And for some reason, you don't get that interferon production like you should, so you don't get viral control as well. Now you get high-level monocyte macrophage activation. You get a lot of cytokines, IL-6, IL-2, TNF, all those cytokines being produced at a high level. Now you get overactivation of the T cells and NK cells. You get T cell lymphopenia occurring, so you get T cell drop, so you don't get the reactivity that you need to form the broadly neutralizing antibodies or the CD8 recovery, because it's lymphocytopenia causes both T4 and Th cells occurring. And now all of a sudden, instead of getting a normal immune response, you get a cytokine storm response, and now you get lung injury, septic shock, and organ failure, and coagulopathy and death. So these are where the different reactions occur, and I hope that, you know, this is where basic science can enter into clinical, where we do go clinically. Does anybody have questions on this? Because we can come back to it. It's very important.
Yeah, we have some questions about specific therapeutics in the vaccine. We also have one on the fatality rate of COVID and the flu.
Let me go into the therapeutics. You helped me get into my specific area here. So I'm going to skip this slide and go into this. This is a much more descriptive slide. So let's take some time and dissect this. So now we see different depictions here. We see stage 1, which is early infection, which might be mild infection. Stage 2, pulmonary phase, where now we have the hypoxia, you know, the FiO2 less than 94%. And then the stage 3, the hyperinflammatory cytokine storm. And so we see these different areas. And so we see the severity of illness. So first of all, we see this one triangle here, and it's viral response. So now, imagine the person just getting infected with COVID-19, and now he's starting to get mild constitutional symptoms of fever, dry cough, but he's still oxygenating well. But now his lymphocyte count start to drop a little bit. So he's got early stage disease. So far, there's been not any real immunological activity or nothing significant enough to make note of. But now we get into stage 2, the pulmonary phase, 2A and 2B. 2A is greater than 94%, 2B is less than 94%. And now we start seeing more dyspnea, more cough, high fevers, chest x-ray, multiple abnormalities on chest x-ray, elevated liver enzymes, maybe other manifestations as well. Now we see here that we're entering into the era of persistent viral activity, but maybe not as high as initially, but now the cytokine, the body's immune response is starting to get active about it. And especially in the second half of stage 2, the 2B, where we're starting to see it being revved up more. And then finally in stage 3, the hyperinflammatory condition. Now we have ARDS, acute respiratory distress syndrome, systemic inflammatory response syndrome, shock, cardiac failure. Now the cytokines are out of control. They're all elevated. The troponin, the D-dimers, the pro-BNP, which indicates cardiac disease, and all the others. And now we're into a different area. So 3 different phases. Now let's look at the bottom line, therapy. First of all, in the early area of the viral response treatment, what they're looking at there and what isn't listed in this slide is they're looking at areas to try to mute or control the virus at that stage, because we're mainly dealing with viral replication, not any inflammation yet, viral replication. So what can we do to try to control that? Well, they're looking at plasma, monoclonal antibodies, either manufactured monoclonal antibodies or plasma from people recovering from COVID-19. These are active, broadly neutralizing antibodies that if we get somebody early in the stages, could we block viral replication, lower that curve so we don't have as much virus that's replicating, that's contributing to more and more inflammation. So they're looking at those treatments, broadly neutralizing antibodies, either in plasma exchange programs, IVIG, or monoclonal antibodies in early stage of disease, or even in prevention. So you have a person that's been exposed to somebody with COVID-19, prevent it from occurring, give them the broadly neutralizing antibodies. So if they do have virus that is incubating at this point, it's going to block it before it can even get anywhere further. So this is what they're looking at right now in stage 1, that type of treatment. We don't have anything else at that point. Let's look at stage 2 now. Well, we still have viral activity going on, But in stage 1 of, stage 2, but in 2A, we don't have hypoxia yet. We don't have evidence of, a lot of inflammation yet. So right now they're looking at remdesivir. Remdesivir is an antiviral. It works on the RNA-dependent RNA polymerase of the virus. So it's direct antiviral. And we're looking at that. And where they found remdesivir to be most effective therapeutically in reducing days in the hospital versus placebo, they haven't quite shown mortality benefits yet, but days in the hospital is during this stage, during where there's still active viral replication. Once a person gets on a ventilator, they haven't really found benefit of remdesivir, and that's where you see the slash line in there. So remdesivir is an antiviral used in stage 2. What about dexamethasone? Dexamethasone is anti-inflammatory. So where would this be most useful? Well, at the time when the patient starts developing the cytokine storm. So they found it most useful in people that are on oxygen therapy, not people that are in the hospital without oxygen, but on oxygen therapy, where their PO2 is less than 94%, and also probably most effective when they're on the ventilator on ECMO. And that's when you have the high-risk cytokine storm and that. So you can see the different therapies, and the 2 therapies that are approved to treat COVID-19 in 2020, today, whatever date that is, October 23rd, 24th, is remdesivir and dexamethasone in that sequence. Now I hope the students can see where you've taken basic science and implemented clinical therapeutic measures based on basic science principles. Questions?
Yeah, so we have a lot on therapeutics, well, about 4. So the first one is, can you talk about Regeneron and its mechanism of action?
I think Regeneron is the monoclonal antibody, and that was what was given to President Trump. And that is used, that would be most effective in the early stages of therapy there, where it's used in the viral response, where you have a high viral load, but you haven't had any real effects on inflammation yet. I think they've used it, and I've read so many studies lately that I forget some of these or confuse them, but I think using it later on, it hasn't had the clinical effectiveness that it had in the early stage when it's mainly blocking antibody or blocking viral production or viral proliferation at an early stage. So that's where it's been found to be most effective, and where they're looking at it is in stage 1.
Okay, the next question is about people who were prescribed azithromycin to fight the virus. So they said time and time we were told in medical school that we should only prescribe antibiotics for bacterial infections. Is there any research showing how an antibiotic such as azithromycin mechanism of action is acting against a virus like COVID?
Good question. And some of the macrolides have both an anti-inflammatory property as well as a antibiotic property as well. They don't have any antiviral whatsoever. So it's mainly based on the anti-inflammatory principles. And actually it was used with hydroxychloroquine as being most effective. And hydroxychloroquine actually works when the virus infects the cell, it hits the receptors, and then it turns, it's in like a little vesicle that gets into the cytoplasm of the cell. And then that little vesicle dissolves itself, and then the virus then encoats into the RNA and the all that stuff. The hydroxychloroquine works in that vesicle to prevent that from dissolving, so to speak. And so that's where but hydroxychloroquine has had a lot of use clinically. There's been a lot of clinical trials, both randomized and just non-randomized. But in summary of that, it's really never been found to be effective in somebody with COVID virus. So that's really kind of, and azithro is not used as a isolated agent. It's usually used with the hydroxychloroquine, but the mechanism is mainly anti-inflammatory. And they've actually found in some patients that have bronchitis and that, getting away from this condition completely, that some of the macrolides may actually be effective, not only because of the antibacterial, but because it reduces the post-inflammatory or post-infectious inflammation as well. So that's the mechanism, but it's not anything you want to use for COVID at this time.
Okay, and this next one is a little long, so bear with me. But we've heard a lot about trial and error related to COVID-19 therapeutics, ranging from outcomes of placebo-controlled clinical trials to the anecdotal pharmaceutical and supplement-based approaches recommended by individual clinicians to the idea of repurposing existing therapeutics as inspired by the recent theory in the bradykinin paper. Some clinicians believe that strong therapeutic agents will be even more important than vaccines given the current socio-political climate and potential issues with manufacturing and logistics. What do you see as the brightest horizon for therapeutics, and what type of timelines might be attached to that?
Boy, oh boy, that is a large question there. I know, let me go to the next slide here. These are just some of the different therapies that have been looked at and are being looked at. And you can see both in the antiviral arena as well as the immunomodulator arena, there's many drugs that are being looked at either as isolated agents or in combination with antivirals. As an infectious disease doctor, my feeling is trying to eliminate the organism before it causes the trauma and the damage. And so, looking at mechanisms of trying to prevent the virus from going from stage 1 to stage 2 would probably be my best shot at trying to control this thing therapeutically if we're going to, look at some therapeutic besides just the vaccine. And I think that trying to look at, a concept like monoclonal antibody, something to slow that viral or get the viral load down enough that if it does stimulate the immune system, like I showed you in that immunomodulator or that cytokine storm slide, if you get exposed to a small quantity, you may actually, get yourself immunized enough by being exposed, but not get into the cytokine storm arena. So my main area, if I was to develop more and more drugs, I'd look at stage 1 in developing rather than stage 2 and stage 3, because the horse is out of the barn, or whatever you want to say, when you're in stage 3 and you've already got multi-organ disease that might be life-threatening and permanent versus, and even stage 2 disease, you're starting down the ladder, so to speak. So I would mainly focus attention, and I think that's from listening to much more experts than I am, and Dr. Fauci specifically, he's very, very encouraged by these monoclonal antibodies, not only as a early therapeutic measure, but even maybe as a prevention measure as well. Giving somebody, say, a shot of a broadly neutralizing antibody, and then if that person goes into a high-risk environment, into a hospital, nursing home, or wherever there might be high risk of not being, having a much less chance of getting infected because he's got that neutralizing antibody there to protect him. Almost like IVIG, protecting you from hepatitis A. Obviously the vaccine is where you want to go, but if you can't take the vaccine or you don't have the vaccine and you're going to a high-risk area for hepatitis A, you're going to take the IVIG because that'll give you, short-term protection. It's not a permanent long-term, but it's short-term. And that might be the same concept with the monoclonal antibodies. I haven't heard of other antivirals. You can see the list of antivirals here. And actually, interestingly enough, this virus utilizes the RNA-dependent RNA polymerase to replicate its genetic machinery, but it also uses proteases to replicate, to induce the polyprotein chain there that, you cut it up into pieces, and each one has a different different property. And that's why they used the old HIV drugs, lopinavir, ritonavir. They used darunavir. And those were agents that were very effective for HIV, but unfortunately not effective against COVID, because the amount of drug that would be necessary to inhibit COVID would be toxic to a human being. So that's where, and then some of these other drugs, the favipiravir, I can't even pronounce it, and those are drugs I've seen, but I can't quote it. In the same category of immunomodulators, think of the basic science principles. Well, IL-6 levels are sky high with the COVID virus storm. And so by using inhibitors, would that be an effective way? And they've tried different trials with IL-6 inhibitors, not very beneficial. And so they're looking at it maybe in combination with other types of inhibitors like JAK inhibitors, which inhibit the, I think it's the interferon gene area there where it might prevent TNF from occurring. I mean, looking at different areas of the cytokine storm to inhibit. But yeah, I mean, a long answer to your long question. But yeah, that's where they're heading right at this point.
Okay, thank you. And there's a question that says, can you address the use of zinc supplementation?
Yeah, that's great. Now, if everybody out there wants to get into something like that, I've been telling my patients, and this is all anecdotal, it's based on studies done in vitro against the COVID virus. And what they found was that vitamin C, vitamin D, and zinc, the triple, has some really good effects on inhibiting COVID virus from replicating properly. And I can't remember the mechanisms. One's an antioxidant. Vitamin D, God only knows, it does so many things. I'm confused. And zinc definitely is an antiviral. And they did a study at University of Michigan where they coated lozenges with zinc and gave it to people versus uncoated lozenges. And they found that the patients that took the zinc-coated lozenges had less common cold. Now, this is before COVID, obviously, but it's the coronavirus. So zinc, I think, definitely has an antiviral property. And I think and so I take the three of them myself, and I tell patients, you're not going to hurt yourself. Go ahead and take it. And if it even gives you 10% protection, it's better than 0. So, but that's the mechanism it works. But yeah, those are agents that have in vitro, but we don't know what it does in actual practice.
Okay, and then another question was, what vitamins are recommended, I believe? And then can you address the use of famotidine in treating COVID-19?
What was the last one?
I don't know if I'm pronouncing it right. Famotidine or famotidine?
Oh, the antacid, famotidine. Yeah, famotidine. Okay. Yeah, that one, I'm going to have to punt on that. I can't give you, I know they've done that. I haven't kept up on that particular area to tell you what the mechanism is or how it works or anything. I really can't comment on that so much. As far as viruses, or not viruses, as far as,
the vitamin question was specifically what dose of vitamin C, vitamin D, and zinc are recommended.
Vitamin C is 1,000 milligrams. Vitamin D is 2,000 international units, and zinc is 50 milligrams. Those are your doses.
Okay, perfect. And then last question about therapy and vaccines are, do you feel that COVID-19 vaccine will be a vaccine we will need yearly, like the flu vaccine, or will it be a one-time deal?
Good question as well. And we don't know that until we give the vaccine and start measuring neutralizing antibodies to see how long those neutralizing antibodies are present. And then we're going to have some kind of a guide as to what level of neutralizing antibodies do we want to maintain that gives us protection. And so there's going to have to be a lot of trials on this, because, you're not just looking at a neutralizing antibody, because what if the level goes down below a certain amount and you may be susceptible again? So that's going to require a lot of more studies to be able to do that. But we're going to need a good antibody that gives us information on neutralizing antibodies. And then we're going to be able to tell whether the vaccine is good for 6 months or whatever. But getting into that, let me just explain something about vaccines. And this is the vaccine. And I'm going to have to get off in a minute because I got another webinar at 2 o'clock. But I'm going to kind of give you a little bit. And we can do this more if you like. If the students like this or they find it useful, I can give them more information. If you want to go into more basic virology or if you want to go more into the vaccines, I'm more than happy. But the platforms for the vaccines are 3. Platforms are a nucleic acid platform, meaning the RNA platforms, which is mainly Moderna and Pfizer. The viral vector platform, where they use the adenovirus vector to get the segment of RNA into the cell so that it can cause, the proper antigens to form. And then the third vector is the protein subunit vector. And you can see on the other side that that's the majority of vaccines, 44 of them are protein-based. That's where you just take this, and they're all made against a spike protein. The spike protein is the protein on the left side that attaches to the ACE2 receptor. And so that's the one that you're going to want to make the thing. So these are, now where I'm going with this is that the vaccine that uses the RNA, especially the RNA platform there, the RNA vector, the nucleic acid vectors, or platform, take the RNA segment that of the virus, that particular part that is specifically used by the virus to make the spike protein. So it inserts it into like a little lipid vesicle that then gets taken up by the cells of the body, and then the cells take this RNA and then produce the antigen that would represent the viral spike. So what the body does in response to that is that the body reacts to that. And the fact that this RNA is within the cells, it will produce two types of immunity. It will produce a long-lasting T-cell immunity with memory cells, as well as cells that produce broadly neutralizing antibodies. So theoretically, this type of vaccine may not only provide us levels of active protection with broadly neutralizing antibodies, but it may provide us a memory cell that remembers that particular antigen. So if it's re-exposed to it by a re-exposure to, say, COVID, it's going to make more antibodies again in response to that vaccine. So theoretically, the RNA vectors or platforms are going to be making both memory cells, T-cell mediated immunity, as well as B-cell related immunity. So that's an important concept. The actual protein base takes a part of that spike protein and then uses an adjunct, and an adjunct is another protein that helps to hyperstimulate the immune system. So sometimes if you just take the spike protein by itself, it may not be strong enough to stimulate a heavy-duty antibody response. So they use the adjunct to give you a higher level of antibody response. That one will be more specific for broadly neutralizing antibody production, may not produce as many memory cells since it's not intracellular like the mRNA, messenger RNA type phenomenon. So those are the two types of three different platforms, and then the two different, and then the different mechanisms. So in answer to your question about how long is this vaccine going to be used for, good question, but we're going to have to just monitor over time. But theoretically, you can see where the different vaccines have different potentials as far as trying to, maybe give you a longer lasting memory cell versus just broadly neutralizing antibodies. Now, the scary thing is safety versus efficacy, safety versus efficacy. Remember that this spike protein, you see it there, it's got the little bump at the top and then that long stalk there. If the body reacts too vigorously and it reacts to too much of that spike protein, is there a theoretical possibility of causing an induction of the cytokine storm versus just an induction of a normal immune response? You have to be very careful, and these are answers I don't have these are questions I don't have answers to. So we have to be very careful of that premise, because that's where we have to be very careful about the safety of these vaccines. These vaccines right now, Moderna is probably at the top of the list, and I think Pfizer is next. The AstraZeneca and the Johnson & Johnson had a couple of side effects. I forget which company. I think it was AstraZeneca had a transverse myelitis, so they put their trials on hold in the United States. Europe is still doing them, and Johnson & Johnson had some other side effects. So two of them are still monitoring for those. The Moderna and the Pfizer are in phase 3 trials, and Moderna has just got their maximum amount of people, I guess, but they're looking at healthy individuals, young individuals. They're looking at older people, greater than 65. They're looking at immunocompromised people, including HIV patients. And they're looking at people with comorbid diseases and African Americans and Hispanics. You got to look at all those parameters before you can say this vaccine is going to be useful. What I can tell you is, and this was something I believe I saw in Dr. Fauci's report, was that there's different feelings about this vaccine. And you have the Caucasian or white individuals that I think are greater than 60, about 60% said they're going to be front line to get this vaccine. The Black African Americans, there's about 25% of them that say they're going to be on the front lines because they're a little bit more skeptical. How safe is it? Is it going to be good? Are we pushing this along too quickly? And Hispanics are in the same various. So we won't know how many people actually are going to want to get this vaccine initially in that first wave. I know they're going to push it for the healthcare providers, number one. Then they're going to push it for, I think, older people and people with comorbid diseases as a second wave there. And then after that, then you go less and less. And I think the young people children that are going to be in the final category way at the end there. So I'm going to have to leave. I can maybe take one or two questions, but I'm going to have to leave here to get to my next thing. You have questions on the vaccine?
Hi, Dr. Gulick. It's actually perfect. We have two last questions, but they're unrelated to the vaccine. The first is, can you provide the fatality rate for COVID and the flu and compare the two?
The COVID fatality, it's the case fatality rate varies where you are in the world. The one that's been reported here is 2.3%, but even if you look at the states and individualize it in each state, I believe our state had a higher case fatality rate, and I haven't done it recently, but it was at least 7%. And the reason why certain states have a higher case fatality rate than others is if you're dealing with more minority patients, more African American, more Hispanics, because their fatality rate is much higher than if you're dealing with a population of young people that get infected that don't have those specific groups in their particular state and things like that. So it varies, but the average in the United States is 2.3%. In Italy, it was actually at 1.11% because the population that got infected there was an older population, and apparently they had a lot of case fatality rate, or they had a lot of comorbid conditions there. So it varies depending on what area of the world you're looking at and what population of patients and you're looking at in the state. What was the other question?
The last question is, how close are we to determining binding/neutralizing antibodies to detect immunity versus exposure?
Oh, that I don't know. I don't know where, that's a good question as well. I don't know where we are as far as the antibody research yet, as far as looking, how close we are to finding antibodies that will help us detect neutralizing immunity versus those that are just telling us, attachment, just indicating that you've been exposed versus neutralized. So yeah, I don't have the information on that as of yet, but that's something I'll be researching.
Thank you, Dr. Gulick.
Now, one last thing before I leave, and I got 5 minutes now instead of 10. This is something I want you to think about. Long-term consequences. This is my final slide. They have what's called long hauler clinics, and they're developing all over the country. They have in New York and San Francisco and several, and we might be developing a couple here in Michigan. But these are individuals that have recovered from COVID as far as their acute symptoms. The symptoms have gone away. There's no longer any virus that's detectable. They've made it off the ventilator. They made it out of the hospital. But now they have these long-term complications, cognitive changes, myocarditis, progressive fatigue and debility, chronic lung problems from the scarring from the lung infections, renal complications, including dialysis, and maybe even post-strokes. What is the long-term consequences? How long are they going to develop? And what are their anti-inflammatory or what are their inflammatory cytokines doing at that time? Are they IL-6 high, D-dimer? I mean, what are all they're developing clinics to study these individuals in more greater length. So these are being looked at, and there's data being collected all over the country on these clinics. So these are some that you're going to be hearing about. They're called long hauler clinics or post-COVID clinics. And that's where I'm going to leave you with that. And with that being said, I'm going to have to depart you. I hope this was really informative. I hope everybody got something out of it. If you'd ever like me to do a repeat or concentrate on one area, a specific area of either testing, vaccines, pathophysiology, whatever you want, I'll do it. But those of you that are going to go into the cardiovascular system, if you're in it, there's a talk specifically related to the COVID complications of the heart.
Yes, Dr. Gulick, we won't take up too much more of your time. We just wanted to say thank you so much again. We really do appreciate it. And we got a very, very positive response from all of our attendees today. So, thank you for taking the time to really teach us about this.
Well, Derek, thanks for organizing it. You did a wonderful job, and I give you a lot of credit. And if you want it again, let me know, and I'll be glad to do it.
Perfect. Thank you, Dr. Gulick. Happy Friday.
Same to you. Take care. Bye-bye.